Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening and would like to welcome you to our webinar on non-medical treatment of tics, an overview of CBIT and Rutgers Tourette Syndrome Clinic. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Hartke answer the questions at the end of his presentation. We will get to as many queries as time allows. In addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would just like to watch it again, an archived version will be posted to our website. We value your input, and in order to expand the webinar experience, we need everyone to fill out the survey when you exit the webinar. New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented. We do not endorse any recommendation nor opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Barbara Chabner, the Program Manager of NJCTS.
Thanks, Kelly, and good evening, everyone. Welcome to tonight's webinar, which, as Kelly said, is non-medical treatment of tics, an overview of CBIT and the Rutgers Tourette Syndrome Clinic. The webinar will provide an overview of comprehensive behavioral intervention for tics, which is a structured evidence-based non-medical intervention for tics, which is based on cognitive behavioral therapy. Our presenter for tonight is Dr. Graham Hartke. Many of you may be familiar with Dr. Hartke, as he's presented several webinars for us over the past several years. Dr. Hartke is a licensed clinical psychologist who has a private practice in Roseland, New Jersey, specializing in cognitive behavioral treatment of anxiety, obsessive compulsive disorder, depression, tics and Tourette syndrome, ADHD, oppositional defiant disorder, and high functioning autism spectrum disorder. He also specializes in the area of applied sport and performing arts psychology. Dr. Hartke works with children, adolescents, and adults, providing therapy, behavioral assessment, and psychological evaluations. He is also a New Jersey certified school psychologist, school supervisor, and school principal. Dr. Hartke became connected with NJCTS initially several years back when he was a student training at the TS clinic at Rutgers. And today he currently serves as the clinical director of the Tourette Syndrome Clinic at the Graduate School of Applied Professional Psychology at Rutgers University. So without further introduction, I'd like to turn the program over to you, Graham, to begin the presentation.
Thank you, Barbara and Kelly. And I would like to welcome everyone tonight to the webinar. This time is the first webinar I've done for NJCTS where my video is on. So I can't see myself. I took it off because it just takes up the whole screen. So hopefully, if there's like something that flies in my face or something like that, just let me know. I'll brush it off. But I'm not going to be looking at myself. So today we're going to be doing a webinar. I'm going to give you an overview of CBIT, and I'll talk a little at the end just about the Rutgers Tourette Syndrome Clinic. I just want to say that this is an overview. The webinar, it's a short platform. It's not a training for someone to do CBIT, and it's not also treatment for somebody. We're just going to give you an overview. But hopefully this could clarify and discuss, we can discuss some issues related to it. All right, let's get on with it. So today's webinar, we're going to do an overview of TS and non-medical treatment. This will be not a really in-depth overview, just kind of covering some key areas related to CBIT. And also I recognize that some people on here are experts and know a lot about TS. Others might just be, this might be all new, so I want to provide some information, but I'm going to tailor it towards how it's relevant to CBIT. Then we're going to do a CBIT overview, and then I want to talk at the end, or mostly about a lot about the process of doing CBIT, because I think a lot of people can describe it, they can read about it, but since I've been doing this treatment for over maybe a decade and a half, and worked with many families and individuals of all ages, I hope to just share a little about the process of how it works and some things as we go. Also, at the end, we'll talk about the Rutgers Tourette Syndrome Clinic. Okay, and I have some resources on here that we can talk about at the end. So let's do a quick overview. And let me just make sure I have the time. Okay. So Tourette syndrome is a neurological disorder. Okay, so that is something that I repeat very often, but it's neurologically based, and it's characterized by tics. Tics are sudden, rapid, recurrent, non-rhythmic, repetitive motor movements and vocalizations. There are two major categories of tics. We have motor, which are movements of different muscles in your body, and we have vocal tics, which are or phonic tics, which are sounds. We also categorize tics as simple or complex. Simple tics involve a few muscle groups, and complex tics involve multiple muscle groups. As far as official diagnosis is concerned, the latest diagnostic manual, the DSM-5, we have these are the main diagnoses for Tourette's and tics. So Tourette disorder is really having multiple motor tics and at least one vocal tic present during the course of having Tourette syndrome. So really, it is just a way of describing that you have multiple motor tics and at least one vocal tic. It's a historic name, but it really describes having multiple motor tics and at least one vocal tic. And really, one of the key things is most people have symptoms and before age 18, usually way before that. The other diagnostic criteria is chronic motor or vocal tics. So these are individuals that really just only have motor or vocal tics. And for both Tourette disorder and persistent or chronic motor vocal tic disorder, you need to have it for at least 12 months to have those diagnoses. Otherwise, you get what we call the provisional tic disorder. It used to be called transient tic disorder, which means your tic really, it lasts more than 4 weeks, but it's no longer than 12 months. So really, there's a range of different presentations of tics, and someone who might have a chronic motor tic diagnoses, it might change to a Tourette diagnosis when they start having a vocal tic at a later age. Honestly, the diagnostic criteria is relatively historical in that we don't really need to distinguish between Tourette's and chronic or motor vocal tic because it really just describes tic disorders. So I think the label Tourette has a lot of weight to it sometimes for some people, but really it's a way we describe a tic disorder where you have multiple motor tics and one vocal tic. Okay, so when we're talking about the treatment today, CBIT applies to all of these tic disorders. So key elements of tics for CBIT. So tics are usually preceded by a physical urge, okay? Tics also naturally wax and wane, okay? So in the course of having tics, they just naturally will increase and decrease in different areas. We're going to talk about more about this in a second. Tics can also be influenced by internal and external environments. So it's neurological, but how we feel and what's going on around us can influence how tics are manifested, or how they're basically really how someone's experienced them, right? So if someone's very stressed, or if the environment, they're feeling that they have a test that day in school, they might have more tics, right? So the environment can influence the tics. Tics are also mostly involuntary, but there's often some temporary voluntary control with sustained effort. So these are some key elements about tics that are important for CBIT. So let's look at this a little more closely. So we're going to talk about the urge. So the physical urge is called the premonitory urge, okay? So individuals can usually anticipate tics. A lot of times individuals are not aware of it, but with a little bit of training and practice and just education about it, oftentimes for many tics, and I would say most tics, in most cases, individuals can perceive some kind of feeling right before the tic happens. With kids and even adults, sometimes we use different words. Instead of premonitory sensory urge, we might say the tic signal or the tic urge. And it often is felt as a sensation occurring in the muscles expressing the tic, but it doesn't always happen exactly where the tic occurs. So one thing about the premonitory urge is that it's usually around where the tic occurs, but not always. So that's one thing in CBIT that we want to be aware of. And it's usually described as a tension or other physical feelings. So it could be an itch, it could be a pressure, it could be just a feeling that something's not right. And the tic temporarily relieves that feeling, right? So that's kind of the process, is that usually individuals have some kind of physical urge and it's relieved by the tic. So the best analogy that we have is usually, it's like having an itch. So imagine your arm is itchy and you scratch it, right? The itch would be the physical urge, and then scratching it would be a tic in that example, if that was, to try to relate to it. Let's look at waxing and waning. So tics wax and wane. They go up and down, they change and vary naturally over time and context in multiple areas, in multiple ways. So they could change in the type of tics. A lot of times the first tic someone will have will be around their head. So oftentimes for motor tics, it's eye blinking. Vocal tics is some kind of sniffling or throat clearing. And over time, tics can, just change throughout their body. Usually goes from a head to torso kind of process, but it can be different ways for different people. So it also changes in how many tics someone has. Someone might have 3 tics when they are 5, and then they kind of go away, and then when they're 10, they have 14 tics. So the number can really change over time. The frequency, intensity, so how often they're having the tics, how strong they are, the complexity, so if they're just simple tics or they involve multiple muscle groups and movements, and even how they present themselves. So someone might have a vocal tic for shouting, and then they stop shouting and they start squeaking. It's similar, but it just changes a little bit in the nature of it. So by nature, tics do this. Something that has come up in the presentations I've done over the past decade or so in describing this and talking to parents and families is that, one thing you would say with tics is that really anything goes, that most movements you could think of could be a tic and probably have been a tic before. It doesn't mean you're going to have all the tics, but it's possible. And to almost expect the unexpected, to expect that, okay, something else different might happen in the future. Why do we have waxing and waning? Really, the thinking on it is that there's neurobiological factors responsible for tic initiation. So it's neurologically based, and the urges are neurological. And the general pattern of waxing and waning has a neurological basis, but also there's an interaction with the environment that may explain tic variability. So, tics might wax and wane throughout the course of a day. For example, there are some kids or adults, but that will experience many tics when they are, on screen. So if they're on their iPhone or iPad, they're off the iPad, not ticking as much. So it can wax and wane within, a few hours and minutes based on the activity, but also it generally waxes and wanes over months, days, years. Okay. So tics are influenced by our internal and external environments. This is important. This is kind of from like a functional behavioral standpoint, but it's important to kind of look at, different types of antecedents and consequences. So the reason this is important is that the environment can be modified to promote some tic increase. We can make people tic more if we have them in front of a microphone speaking in front of a large crowd. If that makes them nervous, maybe they'll tic more. Or we wouldn't do that just to make their tics more. Or we could reduce someone's tics maybe by having someone in a quiet place, or with someone who plays music might play the piano and their tics decrease. So by adding things to the environment, sometimes it can promote changes in tics. So for example, if we look at internal, which means how we feel, our moods. Where is my mouse? It's not on the screen. Okay, I can't point to it for some reason. But for internal, we might feel before a tic occurs, someone will feel a premonitory or tic urge. They also might feel stressed. They might be in a certain mood. Then after a tic happens, right, the tic urge might reduce because the tic took away the urge temporarily. And there might be other emotional reactions. Someone could be relieved. They might also be more stressed after a tic because it doesn't feel like it was done the right way, or the urge is still there, or maybe the tic involves some kind of self-injury. So there are different ways to look at it, right? So external, before a tic occurs, someone might be in a certain setting. I knew some students when I worked in a school who, particularly this one student who started to tic only when he was around a group of 1 or 2 students. I guess there was about 3 students. So a group of 3 students in this class, was not ticking as much around other students, but when in that class around the students, the tic started to really happen a lot. So sometimes it can be very specific and conditioned to certain situations. After a tic occurs, we look at external consequences. So when a tic happens, let's say a kid is shouting in class, maybe that he gets removed from the class or she gets removed from the class, and when that happens, they don't have to do their schoolwork for a half hour, right? And that might not be the goal of it, but we want to look at how these factors might be related to the tic. The last area is the involuntary nature of tics. So I had like 6 slides about this, but I cut it down to 3 because sometimes I go off on a long talk about this. But I want to be clear that I'm not implying that tics are voluntary here. Tics, for the most part, are involuntary. There's a neurological basis, okay? The urge that someone gets is not made up or caused by individuals. So, think about if you could just make your arm just itch by thinking about it, to do that, right? So it's not that these tics people are doing these because they want to have these urges and do this. The thing is, though, that there is a slight voluntary component to tics. People can mostly hold back for short periods of time, but they really can't resist over a long period of time. And really only on some occasion with some tics, particularly when someone's really upset or stressed, it's really hard to do this often. So one thing I want to point out here is that when we say voluntary, it's only a short-lived element of control that someone has to make it voluntary. So the best example we have, because when someone's doing this, the tension builds up and ultimately becomes almost unbearable. So imagine that you had a really bad mosquito bite, it was really itchy, and then you just could not touch it. Or you felt like you wanted to sneeze and you just had to hold it back. So yes, you have some control over it, but it's not like total control where it's just easy. Only temporary control and only from the right mindset, right? And you could really focus a lot of energy. It's energy consuming. So this is important. I'm just gonna put this slide in for, to mention this here, that voluntary here only means there's an element of voluntary, not fully voluntary, right? Like you can voluntarily breathe, but you can't just tell yourself, I'm not gonna breathe. Like your brain will just take over and you'll breathe involuntarily. And it's important, and this comes up a lot in schools and other contexts, even in families, to resist being a tic detective if you're around someone that has tics, right? There's no way you could 100% know that someone has tics. And you hear very often that people feel like individual tics did it on purpose and they're trying to, cause problems or whatever the case. But in reality, all the factors that we talked about are why it's tough to say someone did it on purpose, right? So they have urges, and there's also could be comorbidities. So one of the best ways to kind of think about it is, if you feel the pull to think this kid definitely has tics, to remind yourself, we know this individual has tics, right? Stop yourself from worrying if this is a tic in the moment, and assume that the behavior is at least partially related to TS or associated other conditions, right? So realize that even if this behavior maybe this time was more of an impulse control in general, like throwing a pencil across the room at a kid or doing something, it might not have been a tic, we don't know, but just know that this individual does have, neurological difficulties, and whether it's specifically a tic in this case or more ADHD or impulse control in general, it's not worth being a detective about it, right? So what this can cause, a lot of times can cause a lot of misunderstanding, and kids can feel really bad. And there's other things I could talk about this with, but I'm going to move on for now. So I think you get the point. So really quick overview of TS and non-medical treatment. Like other conditions such as autism, we don't know the cause. We know it's neurobiological in nature. The genetic studies, especially the Rutgers genetic study, which is the national repository, actually international repository of genetic information for Tourette's. If you're interested in getting involved in that study, we can give you information about that. But basically it found that there's over around 400 or so genes, maybe a little bit over 400 genes that they think are involved. So it's not just one gene. We do know brain areas that are related to motor and reward systems, such as the basal ganglia or the striatum, are involved, which striatum, particularly with CBIT, is important because that is an area what's kind of a gatekeeper for inhibitions and impulses. There's also some evidence that some prenatal factors, as during pregnancy, might be involved in this as well. Epidemiology, we say 1 out of 100 children have this, but it's a much higher percentage of people in the general population who have some kind of tic in their life, even up to about 30% that might have a tic for a short period of time, a transient tic. But a 1 out of 100 is really what we say for people that have a diagnosable disorder. And males are 3 to 4 times more likely. And it's also reported widely across ethnic, cultural, and racial groups. So it's not like one specific population has tics. This is important too for CBIT, that this usually begins between the ages of 5 and 10 is where you usually see the first symptoms. The mean onset is around 6 or 7. It tends to be most severe between 9 and 13. And tics usually diminish for most people in early adulthood, but not everybody, right? So about a third of adults will have tics to basically the same degree of severity they had at late adolescence. About a third have tics, but it's a lot less, and about a third really don't report many tics. But most of us that work with individuals that have tics or have in the past, if we're working with an adult who had tics, we might still observe some tics and we might not point it out. But really it's kind of about if someone perceives they don't have any tics anymore, that's kind of fine with us. We're not gonna, say, hey, that's a tic and point it out. But what I will say about course, a lot of times girls, and this is anecdotal evidence, and there's some evidence in research about females later in life, will tend to report symptoms a little bit later, whether it doesn't get reported later or they get symptoms showing up later. But I definitely see in my practice a lot over the last several years, a lot of girls coming in around age 13 or 14 for having either their first tics or having tics get a lot worse during that time. So I think there's a little bit, it could be different on, but there are girls that also have tics early at age 5, but I will say that you often don't get as many boys who have a sudden onset later as you do girls. And to diagnose this, you really do need a physical exam, a neurological exam to rule out other conditions. So typically a pediatrician will recommend what we'll talk about before, it'll say watchful waiting, keep an eye on it, at first, and it's going to go on for a while. But eventually it's important to go to a neurologist, particularly one that specializes in tics, to kind of get an exam and rule out there could be other conditions. A neurologist usually won't take very long, especially a trained neurologist, and most neurologists are pretty good at diagnosing tics, will be able to point it out. Okay, so let's talk about treatment guidelines, okay? What I will say about this is a really important article came out in the American Academy of Neurologists last year, I think in September, basically updating their guidelines for the treatment of tic disorders. And why this is really important for our talk today is that CBIT, or the behavioral treatment of tics, was listed as a first-line treatment, which we'll talk a little about the history. That was kind of a big deal. So their guidelines basically have that, to educate families and individuals about tic disorders as the first step. So if someone comes into a doctor's office, a pediatrician's office, they want to educate the individual and the family, talk to the parents about it. And usually what they'll do, if there's not a lot of impairment, if the tics aren't really bothering anyone, they'll say, let's keep an eye on it, because many tics are transient and will go away on their own in many cases. So watchful waiting is just a way of describing. Doctors will say, let's just keep an eye on it. It's not a big deal. Sometimes doctors will give the impression or say, like, don't ever talk about it with your kid. If you do, it's okay. It's more that they're saying that to say, let's just kind of almost calm the parents down, like, we don't need to really worry about it right now, let's just keep an eye on it. But talking about a tic to a kid is not going to make it worse. They'll play off more of if the parents are really anxious and it's like they're making a big deal about it. So it's always important as a parent, it's not a big deal to if you tell a kid it's a tick, or say it's something's a tick, it can be helpful. It's more about how it's presented to them in a way that models that it's not that big of a deal. It's okay. You know, if the kid gets the impression it's really dangerous or scary, then that might not be the best thing to do. But I do get a lot of families that tell me that they were under the impression that they should never bring it up ever with the kid, and that's not really. It's really more a choice of the family, and if you do bring it up, it's okay. It's just you can be calm about it. It's not going to make the tics worse. But often, if a young kid has a tic, it's better just to kind of just keep an eye on it and let it be. But if the kid asks you about it, you can say, "Oh, I think that's just like a tic movement." Sometimes families will come up with their own words like tickle or you know, the twitch or something like that. So I put this in bold. The next area is CBIT. Okay, so besides educating families, watchful waiting, keep an eye on it. They recommend CBIT. So they have studies, and they did a meta-analysis of many studies of CBIT show that CBIT is more likely than supportive therapy and psychological education to reduce tics. And the other area is medication. So depending on the medication, they gave medication a low or medium confidence that it was more likely than the placebo to reduce tics. Now, I'm not going to go through that article with the medications. I have a link to it at the end. But the main thing is that CBIT was on there. So let's just go over the general tic treatments, and then we'll get into CBIT specifically. So really, when you're going to treat tics, right, after getting a proper diagnosis, often you can consider a medication or medical treatments. Usually medications such as antihypertensive, so the alpha-2 drugs such as guanfacine or clonidine. The extended release guanfacine is Intuniv. That's usually one of the first line medications. One of those medications, usually guanfacine, but also they can try neuroleptics. You know, the antipsychotics or atypical antipsychotics are another class they might go to if tics are worse. Sometimes medications will also be given for comorbid conditions. Well, we're not really going to get into comorbid conditions too much today, but it's a route that you know a lot of families will take. Sometimes if tics are painful, Botox can be useful, especially in neck tics. And then in severe cases, you know, they can use things such as deep brain stimulation. Has been tried. You know, in some cases it has been shown to be effective, other cases not as much for tics. Then we have non-medical treatment. So behavioral treatment, CBIT, all right, the hallmark of CBIT and the main part of CBIT that we know is habit reversal. But it also includes a functional behavioral assessment, relaxation. We're going to talk all about that in a minute. But also supportive psychological treatment, education, coping strategy, social skills, and monitoring are part of non-medical treatment, and we'll talk about that too. There's also a bunch of alternative treatments, and I'm not going to get into the pros and cons of that. But I will say there's a lot of things that people try out there. There's limited research on it, and there's some anecdotal evidence. But a lot of families will try this because there's no cure for Tourette syndrome, right? So a lot of times families will say, let's just try it, right? So there are a few limited studies. I think there's like on my hand, I can count how many studies there are for THC and CBD. There was a study recently of CBD and tics, Germany. I think it involved like 1 or 2 subjects. So they're very small studies. It showed some limited evidence. I know there are some older teens and adults that try to self-medicate and might have some anecdotal evidence. So I'm not saying that any alternative treatments don't work, but there's just not as much evidence in them, okay? And then some people will use supplements and other, there's other alternative treatments too, but we're gonna talk about CBIT. So this is the big picture. This is what in reality goes on for a lot of families when they work with tics. Besides, I don't have this on here, but I do think it's really important for families to get a team together, you know, especially if your tics are going to be more than mild, if they're causing some interference. The team will really consist of having some allies in school, and also having having a relationship with the school administration and counselors. Also finding a medical professional that you feel comfortable with, whether it's your pediatrician or a neurologist that's familiar with tics, and then sometimes, also maybe having a psychologist or other mental health professional involved. Teams might involve other people with other conditions as well. Sometimes speech or OT might be involved as well, PT, but just kind of getting your team together. But overall, for tics specifically, most individuals have a combination of just straight up coping strategies that work for them. And a lot of families that come to me, they already have some things that they use to get through the day. They might have a stress ball. They might adjust the environment, like no screens as of this time. They might take breaks, chew gum. Some strategies that people have employed or schools use or they use at home. Then we have standard treatments, whether it's medical, psychological, or just even supportive therapy sometimes. And then educational accommodations is key for a lot of kids, making sure that the school understands, and if they need accommodations either through 504 or through an IEP is in place, and that we have some helpful activities and alternative treatments. Okay. And these may change as kids change. So let's talk about CBIT. And I'm not, this just so you know too, I'm not going to go over the assessment part too much of Tics. I'm going to talk more about CBIT. So CBIT is structured and it's evidence-based, okay? It's non-medical. It's for all ages really, but mostly children starting around age 8 or 9 up, it's probably most appropriate for. I'll talk a little about working with younger kids. So CBIT works one tic at a time, okay? We don't just treat like 8 tics at once. Medication would kind of be more of a global treatment where you take the medication, it might decrease your tics globally. But CBIT really works one at a time. And really what we do is there's 3 main components, right? We want to increase awareness. We want to use a competing response when the urge is felt, okay? And then we want to make adjustments to daily activities to help reduce tics. And CBIT was really, I'll talk about the components of it, but it was really put together by Dr. Doug Woods, who's a psychologist. I think he's at Marquette right now, but he was out of the University of Wisconsin for a while. So Doug Woods is kind of a key name with CBIT. And the treatment's based on an integrated model of TS. So looking at TS as having, like we discussed, a neurological basis, right? It occurs because of genetics and neurological factor, and also that the environment influences it. So this treatment is possible because there's that component where we can influence it through the environment. And basically, the environment interacting with the tics shapes tic expression. So I'm not going to go through all the research, but the main seminal study, the first big randomized controlled study of CBIT was published in 2010 in JAMA, and it found that CBIT compared with supportive therapy and education resulted in greater improvement. There was also a study a few years later showing that it also was in a randomized controlled study, significantly decreased symptoms and was safe and effective for adults. So we have for children, teens, and adults. And there's been a bunch of other studies since. But what we do, here are the components. So we always start with an assessment as part of a clinical intake. Okay, so we will do a standard interview of parent and child and family. Often we'll use some standardized rating scales and observations for behavior, and maybe more specific ones for ADHD, such as the Basker Connors, or the Achenbach scales like child behavioral checklist. And then what we do is we also do what we call the Yale Global Tic Scale, which is an interview, semi-structured interview we do with the family as part of the clinical intake. This gives us a picture of the tics, and we kind of assess that the individual is ready, willing, and able for CBIT. So what I'm going to do now is talk more, like I said, I'm not going to focus on the assessment about the components of CBIT. So the main components are educating about tics and tic disorders, adding a function-based assessment and intervention component to it, and habit reversal training, which I said is a key part of this treatment, kind of the main part, and relaxation training. So let's go through these right now. Well, first we'll go over the goals. The goals of CBIT are such, and this is important because there is no cure for tics, okay? We do not have a cure. So what we try to do is we want to reduce the symptoms of the tic and the tic urge. That is the goal of CBIT. So we're reducing how the frequency, intensity, and duration of the tic and the tic urge itself. We also, especially in cases where it might not work so well for one tic or the other, at the very least, you want to develop and teach tic management strategies so someone can work on managing in the moment, right? And then we also want to boost social confidence and self-efficacy. We want the individual to feel more confident that there is something they can do to help with the tics, and learn about tics, be educated, right? I put this on here, but remember, CBIT is not a cure. Our main goal is to reduce tics, provide ways to kind of manage them in the moment. If the tics aren't reduced overall, at least they have a way to manage it, they know more about it, and we boost confidence. So treatment is typically about 8 to 12 sessions. It could be as short as like 4 sessions sometimes. It can go really fast. If you have just one tic to work on, it responds really quick. Other people might do CBIT for a long time, for several months or on and off for a few years, depending on how they wax and wane. It really depends on the person, how many tics they have, and the waxing and waning. It's appropriate for children, teens, and adults. For younger children, it can work, but it really depends on the child. Kids are different, developmentally. Some kids are, at age 5 are ready to get up in front of a microphone and give like a speech to a crowd of 400, adults, and, other kids are just fine. They're totally normal kids. They just want to play with their toys and they're not really as interested, right? So it really depends on the child, and if they're ready for it, and also if they're motivated at all. So in cases where you have a young child, they're not super motivated, because oftentimes parents will get a diagnosis between the ages of 5 to 8 or 9, and now that it is one of the top guidelines, they'll get referred to CBIT right away, which wasn't the case years ago, which I'll talk about as much. And but a lot of times the child's not really ready, but the parents, understandably might be very nervous and want to know more about it and get this solved. But I just want to point out that CBIT is a behavioral treatment, so it's really important that the child is developmentally ready and willing and able to work on it, right? So we might include, if a kid is on the fence, we might include reward systems and really work with them and take a slightly slower approach to teach it. I'll talk more about this later, but I think with children, you really want to weigh the pros and the cons of starting at a certain age. Like you might want to wait a year or two until they're a little bit older, because you don't want them to have a bad experience and then never want to do it again because they hated it when they did it when they were 5. So it's sometimes it might not seem like you want to wait, but waiting could be the right thing to do until a kid is ready. So one thing I want to point out too is with CBIT, for those of us that do CBIT, the clinicians I know that, it's a smaller group of us, a lot of us know each other. I would say most of us agree that you can use all components of CBIT, or, you could pick and choose which one you want, but there's this, you can go through all of them. But often habit reversal on its own can be very effective. I personally like to start with habit reversal, because if habit reversal works, you might not need to do the other components as much. Treatment is often delivered by a psychologist or other mental health professional who's trained. It involves family collaboration. So we work with the child or teen, or even if it's an adult, we might work with a spouse or a parent of a young adult. As far as, we want them involved in the assessment, having them kind of talk about the tics, and in the education component, so they're getting educated as well. Also in how we model and demonstrate, the tics, model and demonstrate what we're doing to practice CBIT. And for really all components, we include the parents, especially if we're doing function-based interventions. We'll need parents to collect data and kind of help either, implement interventions. The other thing is, along with individual therapy, CBIT has been delivered via an online training program. So Doug Woods has developed an online way to do tics at CBIT at home called the Tic Helper. I believe has some research supporting that. I'd have to double check. I don't remember off the top of my head when that study was done, but I know that if you go to tichelper.com, you could see. I think it might be free, or I don't think the cost is too high. There's also some research recently where they had delivered CBIT in groups. So they had a group of kids and they did it as a group. And it's also just, a diverse group of people are trained to do CBIT. So if you're a professional watching and you do, as we'll talk in, there's ways to get trained in doing CBIT, particularly through the Tourette Association of America. Doug Woods kind of heads that up. There's different training. Often when you go to those trainings, you'll see people from different varied professional backgrounds, physical therapists, occupational therapists, social workers, autism specialists. So just to know, it's not just psychologists to do it. So let's talk about the components of CBIT. very important is to education, right? To learn about tick disorders, and this is why it's important to normalize and be okay with, you know, we're talking about a tick. It's hard to treat tick disorders if you can't at least call it a tick. I don't always call it Tourette's to everybody, you know, especially the young child, or if the family, you know, prefer not to use a word. But I think the word tick is something I want them to at least know it, you know, or a word similar to it. Learn about the behavioral model of tics, which we'll talk about in a minute, how it works, and just answering questions. Okay. The one thing that's really important is to really know if the child is ready, willing, and able to get started. So the functional assessment intervention, it usually involves identifying situations that precede and responses that happen after tics happen that make them worse. So we start there. We want to know if there's any antecedents. So we might ask, like, we have different functional assessment you know, protocols and sheets, and we'll kind of do interviews with families and find out, for example, if there's a head tic, does a head tic happen more when you're watching TV, or does it happen more when you're in the car, or less? And we'll kind of get an idea of that. And then we also find out what happens after tic occurs. Maybe nothing happens, maybe a teacher tells a kid or a parent tells a kid to stop a lot, and that's something that we want to know. We basically use this information to develop some strategies for modifying the environment. We might ask somebody to, you know, for example, antecedent intervention might be to educate others. We might really want to talk to teachers or siblings not to respond a certain way, or well, that would be a consequence intervention. But we really want to educate others, or we might prompt practicing of habit reversal before tics happen. So like we might remind a child, like, look, we're going into the car, so where it happens, remember to practice, right? Or establish routines. There's lots of different ones we can come up with. You know, sometimes it might be to, you know, reduce screen time, you know, things like that. I know I said that many times, but that's a common one these days, especially during COVID when a lot of kids are home on the screens for hours. Consequence interventions, ignoring tics, reinforcing the practice of habit reversal. And for example, let's say a kid gets to leave the classroom every time, you know, when they're ticking, we might say, you know what, why don't you have them just bring their work so they can do their work in another room? We might not do this all the time, but just an example of something that you might do in an intervention. Okay, so habit reversal training is at the core of CBIT. It's the essential component. And this is not a new treatment. Unfortunately, I don't believe this was extremely widely disseminated for many years. So Azrin and Nunn, the psychologists, studied this and developed it nearly 50 years ago. It was shown to be effective for tics. They have a book. There's still some old copies on Amazon. It's called Habit Control in a Day. If you feel like picking it up, you'll see in that book that, you know, they cite evidence that this worked, you know, back in the early 70s. So it's kind of surprising that, you know, for a while, until it got rediscovered kind of by Dr. Woods and others in the 1990s and early 2000s, and really researched, and we had more funding on it, that it wasn't really at the core of treatment. When I was in the Rutgers Tourette's Clinic in the mid 2000s, we didn't do habit reversal or CBIT for tics because we didn't think there was any way to treat tics behaviorally. So that was only 15 years ago, right? So in that time, it's now become one of the first line recommendations for treatment. So I always point this out, that it's not anything new, and it's really a great thing that it's been brought back, because it's helped many people. So there's three main components to this. We're going to go through: awareness training, competing response, and social support. Okay. So this is kind of a key part. When I do have reversal, I'm very big on going over this with people and talking about it. So so basically, the theory behind it is a negative reinforcement model with tics, and I kind of alluded to this before. But when you have negative reinforcement, it means that by removing something, it increases the behavior from happening, right? So by you know, taking something away, you know, then somebody will do something more, right? If they avoid something, then they'll keep avoiding because they're removing something usually unpleasant. So in the tic, and applying this to tics are negatively reinforced because they temporarily remove the unpleasant sensation from premonitory sensory urges. So by doing the tic, the urge goes away temporarily. Just like if you scratch a mosquito bite, it might feel better for a few seconds, but then it comes back again. So the tics keep happening. The function they serve is to remove that unpleasant sensation. So they make it go away, but only temporarily, and the cycle continues. It's like scratching an itch. So what habit reversal does is we want to break this cycle of reinforcement. Okay, this is at the core of what happens. And sometimes I call it like retraining your brain, especially when I work with kids. So basically it starts with awareness training. So this is where we describe the tic in detail. We really want to know everything about it. A lot of times people just do the tic and they don't think about it. So for example, if you have a head tic, it's your head's moving to the right. You might ask, well, where does your head go? Does it go to the right? Does it go to the left? And oh, it goes to the right. Okay, when you move your head, do you also move your eyes? And the child might say, oh yeah, a little bit, I move them up. So you might go through every part of the area around their tic, or even ask if there's other parts of the body involved. Like, do you feel like your stomach's moving at all? Sometimes you might have another part of the body that's not near the tic, that's where an urge is happening before the tic happens, and you want to. So sometimes you just do a scan. You really describe in detail the tic. The next thing you want to become aware of is the premonitory urge, or the tic urge, right? So we want to get better at perceiving it, describing it, and practicing it. And this takes training. Sometimes kids are not aware of it. Sometimes they really don't report having it. But oftentimes, if I ask them to kind of let me know if they feel something in that area, they will start to notice it. And they'll say, oh yeah, I am doing something. Or if I ask just kind of a general question, like, can you just tell when it's going to happen? Do you just know? And they'll say, oh yeah. So I might ask for 5 minutes if they feel an urge, and they go, no. But I go, well, do you just know when it's going to happen? And they'll say, oh yeah. So sometimes we'll just ask that question. And that's really what the point is to we want to eventually try to catch it before it happens, right? So we will practice awareness training sometimes for a whole session and practice over the week if we need to. Or sometimes kids will just know their tic urge really fast. So like, oh, I feel it. And so what it usually looks like is a kid will have a conversation. After we describe the tic, I'll say, all right, now we're going to talk. We'll talk about something you really like. Let's talk about football, how great the Jets and Giants are this year. And we'll talk about that. And while we're talking about it, just raise your hand when you feel the urge. So we'll talk, and then kid will, oh, I feel it. Oh, point it out to them. Great, that's great. Keep going. Oh, so the Giants are great. They look like they're going to the Super Bowl. And the kid will raise their hand. Oh, great, you noticed it. So sometimes awareness training goes really fast. Sometimes it takes a little bit longer. Every tic is different. Remember, we work at one tic at a time. Then once we notice the kid gets good at being aware of a tic, or adult too, we do this with adults, we will try to implement and go and figure out a competing response. So a competing response is basically a incompatible behavior or opposite behavior. And really what we're going to do is what we essentially want to do is catch the tic before it happens, and then hold it, and hold it for longer than anyone usually holds it, until the urge that's there. So imagine if you felt, oh, I feel a mosquito bite, and you don't, and you say, I feel it, and I'm asking you to move your hand away from your arm and hold it and sit with that uncomfortableness for 1 minute until the urge goes away. And what we do is we come up with a competing response, some kind of incompatible behavior that makes it easier for you to hold your tic back. It's not the competing response itself that makes the change. It's the process of not satisfying the urge. We want that urge to go away on its own in a process we call habituation. We think with tics, it might be something we call inhibitory learning, but right now we're still saying habituation, which is basically, over time, it's unconscious learning. You just get used to it, right? So it's like if you go into a cold pool, your body adjusts. There's something about the process of not feeding that urge by not satisfying it, that eventually your brain it just stops sending the signal as much. So we will develop competing responses unique to each tic. For example, if someone has a neck tic, and often we want tics, we might ask them to just hold their neck straight in the middle and just hold it there in that position, right? If they have an arm tic where their arm's flapping up, we might say, all right, I want to keep your arm down. It has to get creative. There's a little bit of finesse to this in working with the other person. I'm going to talk a little more about the competing response in a minute. But I will say that the main thing I think is not talked about enough with this is that we want to not do the tic. The competing response is not the thing that's making the change on its own. It's helping us not do the tic. That's what it does. The last part, if you want support from family and we want to practice at home. So let's talk a little about the competing response. So we want to basically resist the urge, and we want to hold the competing response for a minute or until the urge goes away. And this is often very difficult. Imagine if you could not scratch something that was really itchy for over even 5 seconds. It would be very hard. So while this is easy to describe, it's really not easy to do. It can be very hard to or difficult to even perceive the tics. So we might get stuck at awareness training for a while because it's hard to really know when the tic's going to happen. Or in practice, someone might not have the urge during a session. They might just say, I don't feel the urge. So it's very hard to practice in session. So we might do things in sessions to try to get the urge to happen. The individual is asked to endure this naturally until, like what I said, the process of habituation happens. This is really the thing that really makes the biggest difference, is that this process of habituation, it's similar to what we have with anxiety disorders, but instead of habituating or inhibitory learning happen related to a fear or a mental aspect, it's just more of a physiological. So you feel the urge, you're not satisfying the urge. So I sometimes tell kids, we're going to retrain your brain. I think that's a handy way to describe. We're going to train your brain that it doesn't have to send the urge by not feeding it. And then what happens is oftentimes with less, the tic signal happens less and you don't see the tic. So if we can decrease the amount the tic signals coming, we'll have less tics. And I will say this again, this is way easier to describe than it is to do. So this is something that's important. And I'll also say it's not just learning a skill. So a lot of people say, I just want to learn the skills of how to do CBIT. It's learning the skills as part of it, but you need to experience it. For the treatment to really work, it's not just learning how it works. But need to go through it. Oftentimes having several or a few successful trials of doing the awareness training, continuing response, and holding that continuing response for long enough for the urge to at least decrease. That's what makes the difference usually the most. The skills are really there for after the main trials to help keep that so the kids know how to apply it later. So some elements of competing response, right? And I'm going to point this out for those of you who work in behavioral fields. This is not a replacement behavior. It's the opposite of a replacement behavior. Replacement behavior satisfies the urge another way. We do not want to satisfy the urge another way. We want to do an opposite behavior that basically does not satisfy the urge. So it's the absolute opposite of a competing response. So sometimes people come in like, I have this tic, this tic I do maybe with where I like touch my cheek, and so instead of touching my cheek, I just like put something else. I use my arm to hold my cheek or something, and that's basically the urge is not going to go away that way. So it must be incompatible with the tic. The other thing is we want it not to be obvious to others. So if someone's head tic goes to the right, I'm not going to have their computer response go to the left, because if they're sitting in class with their friends, it's going to be obvious what they're doing. So we really try to make computer responses that are, look as casual and usual as possible. Sometimes it's impossible to make it totally look inconspicuous, but we try. The other thing is, unlike habit reversal for some other things like body focus repetitive behaviors, and we use other things like for stimulus control, for those of you familiar with that, with tics, we usually don't want to use any other external objects. So Doug Woods says you want to be able to do this naked in the desert, so you have nothing else with you. And it's unique for each tic and each individual. I will say that on rare occasions, I will sometimes add another object to help someone who's in competing response for a long period of time, particularly with vocal tics. If their mouth's getting really dry or something, we might have water if they're holding it for a very long period of time. But generally speaking, I don't like to use any extra objects. The social support, we want parents or guardians to be there supporting. We definitely want to reinforce the effort, and we want to give some prompt reminders when they forget to engage, but not all the time. And so I'll talk about this in a little bit. We want to make sure that we don't stress kids out, because it's very hard to practice. So just practice as much as your therapist tells you to do, not anymore, unless the kid wants to. The focus should be on the competing responses, not the tics. And sometimes external reinforcements like rewards are helpful for kids for their effort, because it's very hard to do this. Okay, so one reward that I remember, this one young child was really into a toy, but the toy seemed to change like every 3 weeks. So every time I would go to Target and get this little toy, after the next week I'd see this child, they didn't like that toy anymore. So getting rewards, you got to make sure it's something that will stay in fashion too. But the rewards really motivated this child to practice. So the other component of CBIT, which is not a core component, I mean, you can successfully treat tics without doing this, but it's helpful, is some kind of, it helps manage tics in the moment, is relaxation training. So the formal ones are some slow, deep breathing. Might do belly breathing, we call it, or progressive muscle relaxation, where we kind of tense and relax muscle groups. I've had individuals often where they're not ready for CBIT, or they don't want, or they're not ready for habit reversal, or when they're practicing at home, we might incorporate relaxation in, but really it depends on the individual how much you're going to do. But this can be very helpful to temporarily reduce tics, and to make it easier, especially at times where you need to relax, like falling asleep and things like that. It's not going to work as long-term as the habit reversal component, though. So a little bit about the process of conducting it, and then I know I'm going long, so I'll try to wrap it up. Okay, so this is typically short term, right? But like I said, it can go on longer. So someone might be a few sessions, or they might be a long time and then come back for booster sessions. I might see someone when they're 8 years old and then work for a while, and then I'll see them again when they're 14, and then maybe when they're in college, right? So sometimes it's not uncommon to, come back to CBIT every once in a while to get a refresher or to work on it for long term. But one of the goals of CBIT is to really have the individual be able to do it on their own when they finish. We really want you to learn how to do it and then kind of be able to come up with something that's on your own. And it really has to go with the pace that's right for the individual. So habit reversal often focuses on weekly review, homework, and so I'll have people basically practice what we do in session for homework for a week. And I'll talk about practice in a second. So I know it's on the next slide. But one thing I'll point out is that on the bottom here of this, it can be fun to practice. So this is a kind of treatment where while we're practicing holding a computer response, we could play games, we could talk. I don't have to it's okay if I distract them mentally because we're focusing on the physical urge. And so we can make it fun even though it's unpleasant. So sometimes, I learned how good kids are at chess sometimes when we do CBIT and how bad I am at chess, sometimes for kids that like to do that. So here's an example of a habit reversal session, just kind of an agenda you might have. So it might start with usually a check-in with the parent and client together about what they did over the last week. Did they practice their practice awareness training? Usually I will ask people to practice to start one time a day for like a 10 to 15 minute period. If you notice the tics, either practice being aware of it, noticing when it happens, or practice computer response. So the homework that's official, I usually give a one time a day. Others might do more. But if the kid would like to practice more, I always say you can. I just don't want to make them overwhelmed because usually kids have a lot of other activities going on. Then after doing the homework, I usually will always do a tic hierarchy. So we will review and rate all tics. We'll get a number on 0 to 10 scale for SUDS. We'll select a tic to work on that day, often one that's bothering them the most. Then we'll work on, for that tic, practicing being aware of the tic and then doing a computer response and holding it. The process of doing a computer response, while they're holding it, I usually will ask them for a rating of 0 to 10 scale to tell me how uncomfortable the urge is. If the urge goes away in 30 seconds, right, I want them to hold it for at least a minute. So I'll say keep holding it for a minute because sometimes the tics will come back. If the urge goes on, oftentimes kids will have to hold it for like 12 minutes, 30 minutes. It can go very long. So I will check in with their SUDS ratings about every minute, and I'll kind of graph it out for them as they go. At the end, I'll show them just so they could see how their progress, how it went up and down. Tics don't need to go down to 0, and just doing a little bit of computer response sometimes can make a big difference. But we know that it is good. I like to see it when it goes down, but it doesn't always have to go all the way down the ratings. So then we review with the parent at the end and say, here's what we did today. Let's practice in front of the parent. Here's what I want you to practice for homework, and then they go home. So this is kind of a standard example. Some key points, and I'm almost done. Motivation for treatment is essential. If kids are not motivated, I don't really want to treat them right now. That's kind of where we could try to see if they can be motivated, and sometimes, some rewards, we could teach them and show them what it is, and they'll get on board. But if someone really does not think it's a problem and they don't want to work on it, it's important to kind of address that and see and not just force it. Oftentimes I might ask, like, who's more bothered by tics, the parents or the kids? Often it's the parents, and I understand that parents are concerned and the kids might just not even notice it too much. But if kids are not ready, willing, and able, we can kind of put it off to later, or we can do some rewards. I also strongly encourage, while kids are practicing parents, that's why I only give a few homework assignments, like one a day, not to over hover or push kid to practice unless the kid's on board, because kids can even start out really gung-ho about it and then it's hard to do, and the parents are always pointing out like, hey, are you practicing? I just saw a tick. Are you practicing? Remember to practice. Hey, I'm paying for this treatment. Why aren't you practicing? Those kind of things, which I totally understand that parents say it, but sometimes I've had kids where after a couple sessions they're doing well, the next appointment, kids crying in my office because they're very stressed, because they feel like it's too hard, they can't do it. So the thing with CBIT is we don't have to rush. We do it one tick at a time, and sometimes a little practice goes a long way. And the goal is, the motivation piece is key. Like if we lose that part with kids, then the treatment's not very effective, right? Someone's got to want to work on this. Okay. Also, I don't want kids to hate it and not want to work on it later on in their life, right? It's important how they feel about it. So for practice, we practice in session and they ask you to do it at home. The ideal, and even Doug Wood said this, would be to practice as much as you can until the tick stops. But this isn't usually, I found this isn't usually practical for most people, because the kids play sports or they're in school all day, or they have dance class, or they're not paying attention. So I will often tell kids, like, if they feel like working on it, they can, but to practice, at least do one practice a day. I will say there's a coach effect that oftentimes I'll hear, and students I work with will tell me what their clients have said, or my colleagues, that people often do their best job during competing response with the therapist. There's like the coach effect. So it's, so sometimes, know that, and we work on it, but we want to really get the parents and the kids to be able to do it as best they can at home. What to expect? So this, I would argue with any psychologist that I think that this could be the fastest treatment and the most effective treatment we have is, in psychology sometimes, in that, like, sometimes one trial of competing response can cause a tick to really stop happening. That's not every case, but sometimes it works really fast. Sometimes it doesn't work as fast with different ticks. So every tick is different, every person is different. So someone might have a tick that responded really well, and there might be some tricky ticks, right? They don't respond as well, they're really tough to catch. Eye blinking sometimes can be really a tricky one, because we blink our eyes naturally anyway. We often get some reduction, but we might want to come back and assess it later if it's too tough, okay? So some concerns people have about CBIT, I only have a few more slides, almost done, is that research has not supported that suppressing your ticks will backfire. So by doing CBIT, it's going to make it way worse. This has been studied. All these have been studied. That treating one tick will make untreated ticks worse. Sometimes people report this, and it might be the case temporarily, but overall it's not. Like, some people might experience that. Sometimes it's more relative. They might notice the other ticks more. Ticks also naturally wax and wane. It also can replace an old tick for a new tick. That's not true. That has not been found. And paying attention to ticks in therapy makes them worse. It just, by talking about ticks, people might tick more in that moment, but it's not going to make them worse in the long run. Limits of CBIT. It's not a cure. It does not always work well for every person, right? Some people respond well, some people don't. Can be difficult to practice. You need to be ready, willing, able, and motivated. One tick at a time. So it's, if you have 10 ticks you want to work on in a day, it's not going to work that way. It doesn't address co-occurring conditions itself. So if you're going to work on some other conditions, you might want to add other treatments into it. And it's not always great with young children or the individuals with intellectual disabilities, because it takes some awareness and motivation. And also can be very difficult to find people that do this work. There aren't a lot of people out there, and a lot of people will have a tough time finding practitioners. So real quick, the Rutgers University Tourette Syndrome Clinic, we are in partnership with New Jersey Center for Tourette Syndrome and Rutgers Graduate School of Applied and Professional Psychology. We're approaching our 20th anniversary. I'm not sure the exact, I think it's 2000, but maybe it was 2001 we started, so we're close to 20th anniversary. We have a specialty clinic at Rutgers. It's run by, I'm the supervisor and director. I supervise graduate students who are trained to do CBIT and also other cognitive behavioral treatments for OCD, anxiety, ADHD, depression. So we treat, we're a fully functional clinic, but we're run by graduate students. And we utilize evidence-based treatments. So the therapists there are doctoral students. They're not licensed professionals yet, but they hopefully will be in the future. And I supervise them. We work with children, teens, adults. We have groups, and we work individually. Our groups are social skills groups that we do in the spring. So we have kids and teens. They're going to be remote this year. They were remote last year. We're also getting together to do a virtual group for college students, young adult college students, like college and graduate students. Just as important, we don't take insurance because we are a training clinic, so we couldn't possibly accept insurance. But we do have lower scale of fees often than what you have in the general community. This is last year's students. I don't think they know I'm using their picture right now, so hopefully they don't get mad at me. But it's on our website. We couldn't take a picture this year because we are remote because of COVID, so I don't have a group shot of this year's. But the lady over here on the left is Emily. She's our clinic coordinator actually this year, the one in the white shirt on the left. Our information, if you just do a Google search, Rutgers Tourette's, you'll find our information, and this is our email. Some resources for tics. So if you're interested in finding tic treatment, you could obviously contact New Jersey Center for Tourette Syndrome for providers in New Jersey, or you can contact our clinic. If you're national, because I know there's a bunch of people on here nationally, the Tourette Association of America has, not only do they have a lot of information on CBIT, they have brochures on it, but they also do CBIT certification training. Doug Woods is not always there, but I think he's there most of the time, involved in that training. And so you can look up certified providers throughout America, people that are in your area. With virtual now, you might have more access to people, even if they don't live exactly close to you. I know, for example, someone in Pennsylvania that lived far away from where the nearest provider was, but now with virtual, they can see them, and there's online CBIT. Kelly was telling me there's also a program that Doug runs for training people for CBIT out of Marquette University. I couldn't find their website though. Okay, so I know I went long, but this is an important topic, so I just wanted to make sure I covered it. And does anyone have any questions? Is anyone still there? I can't hear anyone, so.
Still plenty of people here. Thank you very much, Dr. Harkey, for that informative presentation on TS, symptoms, and CBIT as a treatment. We do have a few questions. First, I just want to say, someone did ask about where they can find a CBIT therapist. So I do want to let people know that NJCTS has a list of practicing CBIT therapists in New Jersey. There are several of them. So you can call our office at 908-575-7350 or email our info box, info@njcts.org, and we'll be happy to get you a list or a few referrals for CBIT therapists in as close to your geographic region as possible. So a couple of questions for you, Dr. Harkey. Are tics that occur because of a trigger, a specific words, still Tourette's?
Yeah, I mean, tics can occur after a trigger. Some tics are almost like we would call classically conditioned to occur after certain. They do with certain triggers in the environment. So yes, that doesn't disqualify it from being a tic at all. Sometimes people will hear things like, a lot of times with vocal tics, they will, there's just palalia, where you repeat yourself, or echolalia, where you repeat others. So sometimes people will hear a word or they'll say a word and then they'll trigger other tics while they're talking. So it's that stuff. That does not disqualify a tic for being a tic. That often is the case with tics. Not always, but it's not uncommon.
Okay. Next question: is CBIT effective on those that aren't naturally aware that they tic?
Yes, because most people aren't naturally, naturally aware they tic, or well, it can be if someone is able to become aware of it, right? It depends on the person. If someone has no idea they're ticking and you talk to them about it and they're still saying they don't tic, then it wouldn't be effective. If they have no ability to have insight, you're not going to really be able to do CBIT too much. You could try to shape the behavior sometimes, almost like you would do with more ABA. You can sometimes, it depends on the individual, to do an opposite and try it that way, but it's often more difficult. So I would say usually the person having some awareness of the tic is most of the time required, but there's maybe been a few cases where we've attempted it, and also I want to point out that habit reversal there are people that study, and there are there's a guy, Harvey Singer, who is researching using habit reversal with stereotypies with autism, and in those cases people aren't as individuals might not be as aware. So it can be done, but you sometimes need to do other kind of shaping behaviors or ways to kind of gradually get to the point where they're holding back. But I find that most people with tics, you really want to have some kind of awareness.
Okay, great. I have another question here. In your presentation, you referenced in terms of sort of contributing factors that can cause or contribute to TS, you referenced potentially prenatal factors. We have a couple inquiries here as to where they can learn more information about that. So I don't know if you can say a few more words about that or provide a source for people to go to for that.
Yeah, so I'm basing that on some of the research out of the Rutgers genetics studies from Gary Hyman. So I can get more, I could put you in touch with him to talk about, he's if you look up, let's see if I can get on the screen, his websites. Let's see if I could. I don't know if you can still see my screen. Okay. Well, you know what? I don't think I have it on here, but I'll get it for you. Basically, it's not that they know that they don't have any, it's not like, oh, there's a toxin in the environment that, or something you do while in prenatal environments that causes tics. They're just looking at development, and it might be genetically related, that something happens while a fetus is developing with the way the neurons develop around the basal ganglia. They know a little bit more about that than me, but it's not like there's evidence that, if you eat food that had Roundup in it, that this is going to cause it. It's nothing like that. It's what I'm talking about is referring to as the research from the genetic studies. I believe they were doing studies with animal models to kind of look at how the genes that they think are related to Tourette's are influencing prenatal development, and that the connections aren't being made that normally are made in that area of the brain. So it's more related to that. So I don't have the article and to give to you, but I think Gary Hyman, another partner of ours, works with NJCTS at Rutgers Genetics. If you wanted to contact him for more information, he'd be happy to talk to you about that.
Okay, thank you for that. And we can probably provide people with that contact
information.
I
just thought I don't want to just do a web search when I'm on with those people right now, so I'll get his.
No, that's fine. So there's one last question that we'll pose right now. And that is that someone says that their 15-year-old is in CBIT training for a few weeks. Tics have been going on for several months, 5 months, and there is some coprolalia, it sounds like, some offensive words, which are hard to ignore. And he does not want to do the therapy. So are there any suggestions for how to deal with that?
Well, I mean, it depends on the individual, right? But when someone's 15, it's a little trickier if they're not motivated. I really would talk to the individual and find out what their concerns are. And you can see if there's some kind of middle ground, and maybe they'd be willing to try for a short period of time. You could try some reinforcements or rewards. Like, look, if you just give it a shot, but I think with a teenager, you really have to have a discussion with them and find out what's going on. Honestly, I've had those cases. It's tough. I mean, you can't force someone to do a behavioral training, but you can educate them and see if there's a way to kind of motivate them to try. And part of that process is finding out what his or her or their reservations are for doing the treatment. But that's a good question.
Okay. So at this point, we've gone over a bit, and it's getting a bit late, so I do want to wrap it up. I want to thank you very much, Dr. Harkey, for the informative presentation. And any questions that we didn't get to tonight, we will try to have Dr. Harkey answer on our blog. And I'm going to turn it over now to Kelly, who will just wrap things up for the evening.
Thank you for joining our webinar on non-medical treatment of tics, an overview of CBIT and the Rutgers Tourette Syndrome Clinic. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That site is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, Ask the Doc, a Neurologist's Perspective, will be presented by Dr. Michael Rubenstein and is scheduled for November 11th, 2020. This ends tonight's webinar. Thank you, Dr. Harkey, for your presentation, and thank you everyone for attending. Good night.